So good evening, everybody, and welcome to the Wincars Interventional Meet today. Without any further delay, we'll go to introducing our chairpersons for the evening. We have Dr. Bhanu Duggal with us, who is Professor and Head of Department of Cardiology at AIIMS Rishikesh. We have Dr. Tripti Dev as co-chair. She's Senior Intervention Cardiologist at Apollo Hospital, Hyderabad. And we have Dr. Cicely Mary Magella, who's Head of Department of Cardiology at Chennai. So we have also esteemed panelists with us, Dr. Varsha Kaul. She's cardiologist at Batra Hospital, New Delhi. We also have Dr. Maria Jyoti with us, who's consultant cardiologist at Apollo Hospital, Bangalore. And we also have Dr. Shalini Garg with us, who's senior intervention cardiologist at Metro Hospital, Jaipur. And along with this esteemed galaxy of chairpersons and panelists, we have very interesting 3 cases up for discussion today. Our first presentation will be by Dr. Anuradha, followed by Dr. Hani Sharma and Dr. Sindhu. Now, I hand over the session to the chairpersons for the evening, Dr. Bhanu, Dr. Tripti, and Dr. Cicely, for further proceedings.
Okay, we can start with the first case, right?
Yes, absolutely.
Let's start here.
So we'll request Dr. Anuradha to please share her screen and start her presentation. Yes,
right,
I think
you are able to see, right?
Yes, now we can see your screen.
Good evening, good evening all. Thank you very much, Wincars organizing committee for the given opportunity. Good evening all to the chairpersons and the panel members. Here, myself, Dr. Anuradha, I'm working in Apollo Hospitals, Visakhapatnam. And today I'm going to share the case. It is a left main instant restenosis within a very short time of 3 months, and how imaging helped us. Yes. And this is an 86-year-old man, and he's a hypertensive. He underwent a PTCA with a DES to left main to proximal LAD 3 months back at our center only. We only have done that. Now he came back again with the chest pain and a drop positive and ECG showing a non-ST elevated MI. And he underwent permanent pacemaker implantation 4 years back for 6 sinus syndrome. And now he is hemodynamically stable, ECG showing pacing rhythm, and echo suggestive of regional wall motion abnormality in the LAD territory, and with the LV systolic dysfunction E of around 37%, with mild mitral regurgitation. Normal renal function. And I would like to go back. And this is the first angiogram for which he was stented. And this is the, are you able to show the label arrow? Hello, ma'am. Hello.
Yes.
Yes.
Yes, Anuradha.
Ma'am, please give me the remote access. I already
Yes, approved. Yes, and this is the post-stenting result at that time 3 months back. And now the coronary angiogram showing left main again 80 to 90% of the critical ISR, and LCX is showing dominant with a non-critical lesion. RCA is non-dominant. Here we can see the ostial left main again 80 to 90% ISR. Though the angiographic result of the previous stenting was good.
Sorry to interrupt. Anuradha, the first slide you said it's proximal LAD or left main? Sorry.
Ostial left main.
Ostial left main. Okay.
Yes,
okay.
Yes. But previously we'd done left main to LAD stenting, but that was around 3.5 mm stent, and we post dilated with 3.5 and 4. And pre-dilatation we used cutting balloon. But what mistake we have done was we didn't use the intravascular imaging.
So initially it was ostial LAD, right?
LM.
LM.
Yes.
Okay.
Now we have taken the help of the intravascular ultrasound. We have done IVUS, and IVUS was showing eccentric calcification of the left main ostium and distal LM also with a nodular projection. There is an eccentric calcific nodule. That is the reason for the ISR. And now we can see here this imaging showing a calcific nodule with MLA of around 3. So how to proceed this case? What tool we can use for this calcific nodule? So here the options are, one is CABC, but the attendants were not willing in even previous, with the age also with 86 years, there is a risk for CABC. Of course, attendants and patients were not willing. Then what to choose for this calcific nodule, either IVL or ROTA or open NC. So initially with ROTA. For ROTA, in the presence of acute coronary syndrome and LV systolic dysfunction, it is considered high risk. And we never know the efficacy of ROTA ablation in the presence of calcific nodule, unless it finds a favorable wire bias. And IVL also, IVL requires longer inflation to deliver the pulses. At the same time, it may not be fully effective. Actually, we have done an NC balloon preparation. He developed hypertension with longer inflation. So then we have taken open NC because he was not tolerating the longer dilatations. And initially we dilated with 3 mm NC balloon. Then he developed hypertension and we started him on NORIT. Then we have taken 3.5 open NC. Initially we inflated at 32 atmospheres. And we run an IVUS imaging. Still the nodule is not fractured. Then we went to higher pressures, open NC 42 atmospheres. Then again we have done IVUS run, which shown beautifully the fracture of the calcific nodule. Here we can see. Then we have done the stenting, left main to LAD, 4 into 18 mm stent, and we have taken 4.5 and 5 mm port dilatation. And here we can see the final result. And we have run the IVUS imaging again. And it's shown MSA is very good MSA. LAD 9 and LM MSA also more than 12 mm. Here what happened, after post-dilatation, final angiogram shown ostial LCX was pinched. Then because LCX is a dominant one, we would like to make sure whether this ostial pinching of LCX was hemodynamically significant or not. Then we have done FFR to the LCX. And before IV adenosine, it was 0.9 and after adenosine 0.81. So we did not do anything to the LCX. At 6 months follow-up, patient is clinically stable and LV function also improved. And here my take-home message is always ISR, to proceed for ISR is we should know the etiology of the ISR, whether there is an underexpansion or it is a calcium or it is mechanical causes or anything. So for that, imaging helped me very much, especially for this case, because calcified ISR, we all know treatment of eccentric calcification in nodule is always a challenging. And what suitable tools, IVL, ROTA, or open NC? Maybe nodular calcification, maybe IVL is considered an efficient tool, though no perfect tool is available. In our case, with LV dysfunction and ISR with eccentric nodular calcification, the open NC balloon helped the demonstrating the fracture of the calcific nodule. So IVUS is always the guiding tool to assess the efficiency of open NC balloon, especially in my case. Thank you. Now the case is open for discussion.
Dr. Anuradha, that was a very interesting case, very nicely demonstrated. And very importantly, you brought out the point that, the use of imaging in ISR is an absolute must. Because if you have to treat the ISR, you have to know why it happened.
Yes.
So to find out whether it's neointimal hyperplasia, neoatherosclerosis, or a mechanical problem with the stent, that is very important. So imaging helps us to decide why it occurred, and henceforth the treatment is guided according to why it has occurred. Now, in this case, but what is interesting is that you chose OPNNC, which is a good choice. And in the Indian circumstance, it is very cost effective. But IVL can also be used in such a situation.
Yes.
What I want to say is that it does not require prolonged inflation. People feel that all the 10 pulses have to give in at one time. No, you don't need to do that. You can deflate very well after 3 pulses, after 4 pulses, whenever the hemodynamic starts going down. The pulses are not lost. They are maintained. You can re-inflate and deliver the rest of the 10 pulses. So which is why IVL is also a very safe tool in such situations, because it can be inflated, deflated at whatever time you want without any loss of pulses in the balloon. Also, because it is inflated at a low pressure. So in left main situations, it's also very safe because it can be brought down at any time. You're inflating at a low pressure, so very safe. My concern is that now you have 2 layers of stent in the left main, and across a large circumflex, you have got 2 layers of stent over there.
Yes,
So
ma'am. That is
long-term
already done.
implications of this is to be considered. Second, he's an elderly gentleman and a HBR patient.
Yes.
You will require prolonged dual antiplatelet therapy in this patient. That is another concern in this scenario. So these are the 2 things. One more thing, because you already had a left main to LED stent, did you consider of thinking about using a DEB in this situation?
Initially, we were contemplating whether to go with the DCP, ma'am, but after this calcific nodule, because it is a major vessel, big vessel, we would like to go with the stenting, though there is a consent for the metallic burden. We agree, absolutely agree with you. Somehow at one point, we don't think a left main, so I could not dare for DCP actually.
When you already have a
Thought was
scaffold in
there.
place.
That thought was there, but somehow I would like to contemplate maybe this is a left main. Already we done one mistake. I have paid for that because last time I did not use the intravascular ultrasound. This time within 3 months patient came back. So I aimed for a bigger MSA. So I thought of going for stenting. But there is yes, ma'am, I agree. Maybe DCP is also a good option to reduce the metallic burden. We could have done that.
Dr. Bhanu, Dr. Tripti.
Yeah, it's a very interesting case. Actually, we do see such problems when first instance only the intravascular ultrasound was not done. Probably, I feel this nodule could have been there, and that could have prohibited the first stent expansion to the full level. So that nodule, had it been detected in the first instance, you could have prevented this happening. That is one very good teaching point. We understand and we learn it from this that in those instances, we should avoid imaging intravascular ultrasound for left main, especially. And this nodule may regrow again. That is another one future, because these nodules are very susceptible to regrowth. So many times we have seen in our cases also where there was a nodule, we stented and we nicely, debulked it totally, like you have done in the second time. It was very nicely debulked, and you have done the second stent. But still, I think there is a chance that it may regrow, because that is the normal pathophysiology of nodules. And mostly those who are not eruptive type, they will regrow further. So that is the reason that you have to be careful. And maybe you can do one more IVA study, maybe after 1 year or so. Though he is asymptomatic, and it is good for your future direction of treatment, that you may closely clinically follow his elderly man. But sometimes it may be necessary. I don't know in this situation whether CT angio or CT scan, plain CT scan or calcification would help. I'm not sure about that. But we need to have some tool to understand that it's not regrowing further and making him unstable. That is one point. One more point I was thinking, because his LV dysfunction is there, maybe we could have started upfront, IABP or something like that, some mechanical support. So in case, because it's a nodule, it's a left main restenosis, that I might have taken some mechanical support for his LV dysfunction. Luckily, with NORAD support, he was okay.
Yes,
Quite a lucky point. Yes, Dr. Bhanu, you want to say anything?
No, a very well done case. But just for my learning, Dr. Sarita and Dr. Tripti, I mean, once we have cracked the calcium at this high pressure, can we do a deb and leave it? Or I mean, I am not familiar with that. So Dr. Sarita was mentioning, can we, or it has to be stented? You have a fractured calcium there in the left main.
So nowadays, even after rota ablation, many a times we DEB the vessel and we leave it. The idea is if you don't have any flow limiting dissection and you don't have any residual recoil, which is more than 30%, you can DEB anywhere. Now we are getting more and more aggressive with the use of DEB. I can understand the concern of Dr. Anuradha that it's a left main situation and she doesn't want to. And this will only come with experience. But currently, many places, when we come up with ISR, I have typically stopped putting stents inside ISR. Now I only DEB, aggressive imaging followed by aggressive bed preparation and DEB. And that gives us great results.
For left main also, you keep DCB, ma'am? You kept any cases?
Remember, the left main is the worst place to put 2 layers of stents. What are you going to do if he comes back? He's 87, he's got 2 layers, and he's going to come back, I'm telling you. Because what Dr. Dripti was saying, these nodules,
Yes, they may go.
very reclarescent things. They come back. So you've done a great job of it. But the problem is that nodule regrows many a time. So what are you going to do? At 87 years, 2 layers of stent, there is no way that you can come in with a 3rd layer.
Yes.
The risk of stent thrombosis would be too high, and your circumflex with the 3rd layer will pinch off. So this is the issue today, that because of there are more and more complex interventions, more and more older patients that we are dealing with. So there are more and more layers of metal that today we are dealing with, which is why DEB is coming in such a great way and is a good option. At the same time, there is one question in the chat box from Dr. Sarita Gulati. She has asked why orbital atherectomy was not considered. Dr. Anuradha, you want to answer that? Or you want me to answer it?
You please, ma'am.
Because it was your case, so.
Yeah. Actually, orbital was nowhere we thought of actually. We always thought of IVL rota openancy only. Orbital was never a point of discussion and it was never thought actually. Left main we not.
Why orbital cannot be done in this case?
Yes.
Orbital cannot be done in a place where there is a recent placement of a stent. This was a 3-month-old stent. You don't see any major endothelialization over it. Orbital moves in a circumferential pattern. It will get into the stent, it will mangle the stent, and it will make a mess over there. So you don't orbit inside a recently placed stent. You never do it, because it will move circumferentially. It will get into the stent struts and it will break it all up, and there'll be a big mess over there. So this is one of the contraindications of orbital atherectomy. Again, rota, not considering rota is also a good choice, because in this case, you would have had to do a stent ablation. This is a very recently placed stent. So if you want to hit the nodule behind the stent, you would have had to do a stent ablation. And stent ablation can be done by a very highly experienced operator, and typically they avoid in left main.
Ma'am, you told IVL we can, suppose for first 10 pulses, we can stop at 4, 5, 6.
Any pulse. You can stop at 3 pulses also. The rest 7 will wait for you.
Yeah, that is okay. For first 1 cycle, we have to go with that, right?
No, you can give any
Total
number of
10
pulses.
pulses.
Any
Total
pulses.
Total 10.
Total there are 120 pulses.
Yes.
Now,
Now
typically
one-
at one
yes,
time
now
we give 10 pulses.
Yes.
So in that 10 pulses, you can stop at 3 pulse, you can stop at 4 pulse, you can stop anywhere you want. The rest of the pulses remain. They are not lost.
Okay.
People think that if you start giving pulses and you deflate, or you stop giving pulses after 4 or 5 pulses, then the rest of the pulses in that 10 pulses are lost. It is not so. It remains. You can allow the vessel to breathe, re-inflate, and deliver the rest of the 5-6 pulses. Which is why it is considered as a very good tool for left main, because you have a wire into both the vessels. You have a wire into the LED and the circ, which you cannot do with an rotablation. So that is the thing. That is the beauty of this therapy, that for left main and especially for nodule, it works very well. So orbital also works well for nodule, but the problem is that in this case, there was a stent over there. So you couldn't have taken orbital.
Thank you, ma'am.
Can I add one comment?
Jyotsna ma'am, welcome Jyotsna ma'am.
Thank you. As Sarita said, the DEB is the best option in this case. There is no doubt. More complex the case, more bed preparation, and better to do with the DEB. That is the tendency now. That is the well accepted one. Second one is Tripti Devi's subsequent evaluation. What we can do it is now the photon CT is available, where it is an excellent intravascular like images are seen in the photon CT. And especially for the stunt placement, following that, the photon CT films are the very good. So nowadays, we need not to do the re-angiogram to see in asymptomatic patients when a complex cases are done. Thank you.
Thank you, Dr. Jyotsna ma'am. Are there any comments from any of the panelists? Because I could see in between that Dr. Maria Jyoti had raised her hand. Dr. Shalini, would you like to make any comment?
Yes, ma'am. I just wanted to ask, as ma'am Tripti ma'am has described, that patient is elderly with severe LV dysfunction and LCX is also dominant. So haven't you thought of using IABP or any other LV support device while doing this case? Dr.
Yes,
Anuradha?
IABP was kept ready. We thought of if we couldn't go with NORAD, we started hardly 3 ml. If still goes further down, we kept it ready. That backup is always there.
On the standby mode. Okay.
Yes.
So because after open NC also a lot of slow flow is there in my experience with open NC also. So as LCX is dominant, so it might crash the patient on the table also. So that's why.
Yes. Luckily we couldn't. Yes, we didn't get the slow flow, but the IABP option is always kept ready. It was there, standby.
Dr. Shalini, typically, if the EF is 35%, we always keep standby because this is Indian scenario. In Indian scenario, everything costs the patient. So what we do, it hardly takes 1 minute to insert an IABP. So we always take an access and we keep. If we can get away without it, usually you connect, we keep the inotropes also connected. So immediately purging some inotropes, giving some ephedrine, usually trades over. Secondly, remember, these are chronic lesions. So this is a chronic lesion. They tolerate ischemia very well. Transient ischemia is very well tolerated by a chronic lesion. So usually you don't require IABP support in such patients. But an access is always there. The thing is to do the job with the least amount of cost for the patient. So we will, thank you. We will move. There's one more question.
One more question. Why I raised this? Because sometimes they say that we shouldn't use the same drug. Maybe we need to use the other drug. What about the opinion on this, ma'am, when they have ISRs?
So there's always been this thing that if you've had ISR with one drug, next time take a different drug. But that is typically when you have neointimal hyperplasia. In this case, she had a mechanical stent failure. The stent failure was because there was a nodule which had not been dealt with. So it was not a failure of the drug. In this case, it was a mechanical failure. If you have a failure of the drug, which means that you have a beautifully deployed stent, you've imaged, you've had a great MSA, and still your stent has failed, then it makes sense to switch the drug. I hope that answers it.
Thank you.
Yeah.
Anuradha, welcome to the Shakti Enclave with your case. We will be waiting for you.
Yes, welcome. And we have just one last question on this, then we'll move to the next presentation. There is Dr. Sridevi has asked a question. Is there any role of ELCA? Dr. Anuradha, you want to answer or you want me to answer or somebody else wants to answer that?
No, ma'am, we don't have any experience with ELCA.
Okay, so I have ELCA, so I will answer that. ELCA is typically indicated in mild to moderate calcification, 1. Secondly, it's very good for ISR. Typically, neointimal hyperplasia just disappears if you use the ELCA. It's also very good for high thrombus burden. Young patient, acute MI, huge thrombus burden, you just run the laser, it disappears. But ELCA is not very useful in a huge calcific nodule like this. So in this case, ELCA would not have been my choice. Thank you, Dr. Anuradha. That was an amazing case. It sparked a lot of very interesting discussion. A lot of very useful day-to-day learning points were discussed right now. And thank you very much. And I need you to stay on for the rest of the cases and for discussions.
Thank you.
So we'll move to our next presenter, that is Dr. Hani Sharma. Dr. Hani, I request you to share your screen.
Good evening, ma'am. Ma'am, am I audible?
Yes, you are audible. Dr. Hani Sharma is from Indus Hospital, Mohali.
Ma'am, is my screen visible to everyone?
Yes, Dr. Hani, it's visible, but we will require you to go to slideshow. Yes, it's visible. You're audible. Please start.
Okay. Good evening, everyone. I'll be presenting a case of recurrent in-stent restenosis in RCA and then discussing the role of DEB in the recurrent ISR. So this was a 63-year-old gentleman with dyslipidemia. He presented to us in July 2021 with the angina since 5 days. Troponin was 544. And the ECG showed ST segment depressions in inferior leads, heart rate 90. 2D echo was normal with no RWMA. Angiogram revealed left circulation was normal. There was critical single vessel disease with mid RC 100% occluded. At that time, we deployed Ultimaster Tanse 3.533 in proximal LAD and Zions Expedition 348 in mid RCA. So this was the initial, the first picture is showing the initial angiogram, and second is the post-stent deployment. Second presentation was in April 2022. He presented with unstable angina episode since 2 months. And this time also, angiogram showed single vessel disease with left circulation normal, but there was diffuse 70 to 80% ISR in the osteoproximal to mid part, and distal part showed 60 to 70% ISR. We pre-dilated with the NC 215 and 320, and followed by we used cutting balloon 3.25 into 15. And this time we deployed a thin strut Evermime 50 in proximal to mid RCA and Abluminous 3.540 in mid to distal RCA. Post dilated with the NC 3.520 and 415 in osteoproximal part. This was the second presentation that I just discussed. Osteoproximally, it was quite critical. Unfortunately, we couldn't do the imaging in both the scenarios. So within 4 months, second presentation was in April and third presentation was in August. He presented again with unstable angina. This time there was focal ISR at the same point, 90 to 95% ISR in proximal RCA. Initially, we planned for DEB, but unfortunately, post-cutting balloon, he had unstable angina on table and he became hemodynamically unstable. So we immediately deployed the Resolute Onyx 426 in osteoproximal part and post-dilated with 412 and came out. This was the third angiogram. So osteoproximally, it was quite tight. This is post-cutting followed by Resolute Onyx and post-dilating with 412. So a recurrent ISR is defined as a second event of ISR after successfully treating the initial event, the first ISR event. The risk factors and incidents still remain underestimated because of the lack of the long-term results in the trials which are available on the first ISR event. And management is also more challenging and nuanced because of the previous interventions and multiple stent layers, multiple metallic layers. The usual strategies that we use to manage the first event, the DES and the DEB, they have also shown good efficacy and safety profile in this case. But there is limited data available on whether these strategies, they work similarly for the subsequent ISR or not. Incidence and prevalence is still not precisely known. Most of the trials report a range between 10 to 40%. In a recent large trial with more than 48,000 patients with de novo lesions, the second and third ISR, they had 17.1% incident and 22.8% respectively, with multiple stent layers, especially 3 or more, associated with progressively higher incidence of recurrent ISR, whether you treat with DES or DEB. And there's another retrospective study that reported the occurrence of 1.4% in nearly 20,000 patients who underwent DES for native coronary lesion at 10 months from the last revasc. There is another smaller study with 9 out of 55 patients showing 16.4% incidence of recurrent ISR after the first generation DES deployment. The risk factors can be patient-related, related to the coronary anatomy and mechanical and biological factors. Among patient-related, hypertension and dyslipidemia being the most common out of these 4, then CKD and previous MI. And coronary risk factors, non-focal restenosis, RC osteal lesion, as was in this case, stent diameter less than 2.5 mm, and the percentage diameter of the stenosis, acute stent recoil during the second stent implantation for ISR, resulting in the early recurrent ISR. Then diameter at the early follow-up and stent fractures resulting in late recurrent ISR. Then mechanical and biological factors, the intimal hyperplasia, the exaggerated intimal hyperplasia and recurrent events plays the more important role. Then stent under expansion and the calcified and the tortuous vessel that interfere with the deployment of the stent. Then the hot segments, the segments with the increased inflammation. So when you deploy the stent, they further flare up the inflammation. Then malapposition and the stent recoil, and of course the inadequate bed preparation. Most of these patients, they present with stable or unstable angina. There is a small percentage that present with MI, mostly non-ST elevation or with NYHA class 3 or 4 heart failure. The role of non-invasive imaging is debatable in this case. The 64 slice CT coronary angio because of the presence of the multiple stent layers and altered morphology because of the previous intervention. And then artifactual enhancement because of degenerative changes in the vessel wall. There is difficult diagnosing ISR using the CT coronary angio. No doubt the dual source CT and 360 row CT coronary angio provides you better resolution and less dependency on the heart rate with decreased artifact generation, but the availability in our country is the issue. Then invasive imaging, the conventional coronary angiogram is gold standard for diagnosing. And I was not able to do OCT and IVUS in this case. OCT, the gold standard for new atherosclerosis, that is the cause for the late ISR and late stent failure. Then, of course, IVUS for detecting intimal hyperplasia, that has a main role to play in case of the recurrent ISR events. To understand the underlying mechanism of the ISR is most important. As per coronary angiogram, we define it as any lesion within 5 mm proximal or distal of the previously placed stent with 50% or greater diameter of the stenosis. So the Mehran classification, that is based on the bare metal stent ISR. But in case of the DES ISR, we use this Waxman instant restenosis classification, where the type 5 is used to classify the recurrent ISR, the one with more than 2 layers of the stent. It's based on the underlying mechanism of the restenosis. And these are the various treatment options that we have. The plain old balloon angioplasty, it is not preferred as a standalone procedure because of the uncertainty in the durability. And though it gives the advantage that there is no new stent layer, already there are 2 stent layers, and efficacy has been found to be comparable in some of the trials, but the recurrence rate is high. Then second, you can go for the repeat drug-eluting stent that has been most extensively studied in these cases, and especially if there is stent fracture, that is helpful. But and again, it will further increase the metallic layer and the DAPT requirement for additional for longer period. It will be there, and there will be decreased minimal luminal area. Though it has been found to be safe and effective for recurrent ISR, and immediate results are satisfactory, but durability is still questionable. Then we have DEB that has no metallic layer and no antiplatelet therapy is required, and it has been studied extensively. Then we have brachytherapy. Again, the availability with brachytherapy is the issue in our country, and it will give you short-term result. It has been compared with the DES also, but it can cause new atherosclerosis, increasing the rate of the stent thrombosis. So it requires dual antiplatelet therapy for additional 1 year. And there has been seen high target lesion revascularization rates as well. And then surgery. In case of recurrent ISR, European Society of Cardiology has recommended it to be class 2A in the recommendation in case of the recurrent ISRs. So about the role of DEB, as we all know, it releases a lipophilic antiproliferative drug over a short period of time and in very high doses, typically over the restenotic lesions. There is no need to add a new permanent metallic layer, and it takes away the disadvantage of the additional struts, and also the long-term DAPT is reduced. So in high bleeding risk, it is an attractive option. This is the study by Kawamoto. They compared the DEB with second generation DES for managing the recurrent ISR. And the results were equivalent in both the cases. And the recurrence of the ISR within 1 year of the first reintervention and lesion length, they were found to be independent predictors of the future target lesion revascularization. And this was the study chart where in 65 patients, DEB was done as a second procedure, and DES in 68 patients. Then the third PCI was done. So this is another study comparing the DEB with DES for recurrent in-stent restenosis, and especially in the patients who had 3 or more than 3 metal layer DES ISR. DEB was found to improve clinical outcomes as compared to doing re-DES implantation. Contrary to that study, this clinical outcome-based study for ISR, it didn't compare DEB with other treatment options. It was used as a standalone procedure, and rather it was found to be less effective when the layers increased to 3 or more in case of the in-stent restenosis. And the patients who were on hemodialysis and the number of metallic layers were 3 or more, in them it was found to be less effective. This is another small study indicating that it was found to be safe and clinically useful option in high-risk patients with refractory ISR. And this was paclitaxel iopromide coated balloon was used in this procedure with no procedure-related adverse events and late lumen loss at 8 months of only 0.1 mm and 7.1% TLR rate. So this is an effective strategy to manage recurrent ISR, but again, it depends strongly on the optimal bed preparation. As I was saying, the suitability over stenting in recurrent ISR is still not established, and selection of the procedure depends upon the person who's operating and the treatment center. More follow-up results are required to compare the long-term effects of these strategies. These are the take-home points that the patients with the recurrent ISRs, they have only single certainty that their situation is the result of at least 2 prior revascularization failures. So what is the underlying mechanism that is behind the recurrent ISR? That is the turning point of their treatment. And that's why imaging is very important. And stent malapposition or to detect stent under expansion, thus allowing to avoid any further wrong stent implantation. And DEB treatment without further DES is a possible and rational, thoughtful option to avoid another metallic layer. And the approach for every patient should be individualized. Thank you.
Thank you, Dr. Honey. Very interesting presentation with an extensive background data about it also. So interestingly, you stented your patient 3 times, right?
Yes, ma'am.
So basically your patient comes into Waxman type 5. And typically in Waxman type 5, uh, a DEB would have been the best option for the patient. And I think you did not use imaging anytime. So I assume that your center is not imaging equipped, right?
Center is imaging equipped. This was the case that I did in Fortis Mohali. We have OCT
Awesome.
on table, but due to the patient refusal to pay
Financial
for ticket,
constraint.
we were not able to use it.
Understand. So financial constraint is a problem that all of us face. So I can understand that if they refused, imaging was not possible, because imaging would have been vital in this case. But if the patient cannot pay, then that is a problem for us. But the second thing is, why in the third situation did you not use a DEB? Because
So
3 layers
that
of stents would be tough for the patient.
we initially planned for DEB only. When we did cutting balloon, then patient started having angina and he became hemodynamically unstable. So due to the dissection, probably we went with cutting balloon at too high pressure, probably. And that's why immediately we had to deploy a DES.
So whenever we do cutting, remember, if you have 2 layers of struts over there, nothing is going to happen to the vessel. You just give dilators 2B, 3A, hike up the pressures, use supports, and wait. It will always settle down. If you have 2 layers of metal scaffolding over there and you're doing a cutting, nothing will happen. It's always transient. Because you see, by adding a third layer, it is understandable that whenever the hemodynamics go down, the lab goes into a, flurry. But putting a third layer, and typically you have long stents over there, putting in a third layer is catastrophic for the long-term scenario of the patient. I can understand why you did it, but the point is that the long-term results and the chances of him again coming back with a record ISR, because we don't know why it's happening also, because we haven't been able to image because of the constraints of cost. So one is that we don't know why it's happening. The second is, by all the guidelines, if there are already 2 layers, we have to use DB only. So that is the issue in this case. So over to the chairpersons for their comments. But great case, Dr. Honey. Interesting.
So I agree with Dr. Sarita, like putting the third layer of stents should be avoided at all costs, but I think the operator knows what was happening at that time. Only thing is, one is in your risk factors, is diabetes is a major cause of ISR. I always find that patients with high sugars keep coming back. So, which you did not mention, did the patient have diabetes?
The only risk factor was dyslipidemia. There was no family history or diabetes or hypertension in this patient.
So after the second layer of stents, I would have gone for LDLs at decreasing the LDLs to very low levels, even using the newer therapies, so that this does not happen again. And coming to the intervention wise, even sometimes in the first, most of the time, if this patient, if the ISR is of a recent origin, and the patient comes in very recently, it's usually that he has missed a few drugs. So the layers, if you are not imaging, is usually made of some thrombus and a layer of neointimal hyperplasia, which is not very extensive. That time you can even get away with POBA and NC and not go for a cutting balloon. So intracoronary imaging, IVUS is not good in any case of ISR. I would always go with OCT. And once you do an OCT and diagnose, especially the second time, it's good to convince the patient for OCT and do the OCT. So keeping the lipid levels very low in these patients, LDLs around 50 or 40, doing it very aggressively, managing sugars and going for intracoronary imaging is more useful. And I think the cost would have saved him those 2 stents, the cost of OCT. Dr. Tripti?
I agree with you. we keep OCT reusable. Yeah, we really handled it very, very softly and very carefully so that we can reuse the OCT.
At least twice we are able to use
At least
them.
twice, at least twice. In such situations where they are not affordable, for the benefit of the, mechanism of IS, and these cases, they are very much important. Still, we are blindfolded. We don't know what happened exactly. And it's a young
Four, five times.
man. So that's why. Very
Dr.
great.
Dr. Tripti, very true. OCT, we've reused up to 4 or 5 times also. So, Dr. Honey, what we do in these patients where usually patient cannot afford is just reuse one of the old catheters. It really saves the day for us. There's also one comment from Dr. Sarita Gulati in the chat box. Again, she's emphasizing the fact that in the setting of recurrent ISR, intracoronary imaging is mandatory.
Yes, ma'am. Initially we planned and we asked for OCT. We have that in our center also, but unfortunately we were not able to use it. And I'll keep that in mind from next time onwards.
Any comments from any of the panelists or Dr. Jyotsna, Dr. Sujata, Dr. Shiva?
Yeah, just I wanted to add in many of the cases we talk about brachytherapy. Actually, when we were doing our fellowships, we used to do the brachytherapy, but that time it was a instant restenosis because of the metallic stent. So brachytherapy was very famous at the time and is completely fade off within 4 years because of its stent thrombosis rates are so high. It's not that on-table stent thrombosis, but subsequently. Also, the stent thrombosis, the incidence used to be continuously high for the next 1 year. But once 1 year is crossed, the stent thrombosis rates was very less. Now, again, it is the resurging one of the mechanism with the change the content of the brachytherapy. I think it is now again going to come for the so much of resistant cases.
What is the best modality to diagnose stent fracture? Anyone, Dr. Sarita, any panelist?
So I think either it would be
OCT.
So typically we are able to see the stent struts very well on the OCT, but also on a CT. You can also see it on a CT.
Sometimes on the boost, I mean, we do.
Yeah, that's what I was
but
about
sometimes,
to say. Stent boost also
on the
is
stent
used.
boost. Yeah, no, it's sometimes confusing, right?
Yes, sometimes yes. The stent boost, but
with multiple layers, I think
that's
it
a
becomes
very-
really difficult.
true.
For single layers, I think stent boost instantaneously is a good option before we go for imaging. It gives us an early idea about stent fractures.
True. Point well taken. So, Dr. Honey, that was a great case. And the operator in the lab, whoever saves the patient, that's the best operator. The patient goes home well, is the best patient treated best. So, thank you so much for that amazing case. In the interest of time, we will go to our last presentation by Dr. Sindhu. Dr. Sindhu is a consultant intervention cardiologist at AG Padmavati's Hospital, Pondicherry, and she's going to show us a case about managing a complication. Over to you, Dr. Sindhu.
Yeah, ma'am. Good evening. Is my screen visible?
Not yet.
Okay, I'm just gonna. Okay.
Yes, your screen is now visible.
Yes. Is it okay, ma'am?
Yes, perfect. Please go ahead.
Yeah. Good evening, everyone. This is Dr. Sindhu from AGP Hospital, Pondicherry. I'm going to talk about how I managed a disaster. I have a 65-year-old male who was admitted for effort angina class 3. He had a history of anterior wall MI, which was diagnosed in 2018. It was lysed with streptokinase in an outside hospital. He was stented with, I don't know the details, but stented to the proxy lady, which is also done at the outside hospital. He presented to me with an ECG, which had old anterior wall MI changes, an echo which showed a moderate LV dysfunction, an EF of 42%, and anterior wall hypokinesia. So this was the baseline angiogram. His circ was normal. His left main is normal. The stent to the prox LED was normal, and a mid LED had a critical lesion. His mid LED has a critical lesion of 70% at D3 and distal LED of 99% stenosis, the good TIMI3 flow. He had normal right dominant system. So he was taken up for the procedure. PTCA to LAD was done through the right femoral approach. EBU3 was used, and he was wired with the run-through thermo wire to the LAD. It was parked in the distal LAD, pre-dilated with a 1.510 NC balloon, the usual, stented with 2.2520 everolimus drug-eluting discs deployed at nominal pressures, and the mid-LAD stent was overlapped with the previous proximal stent as well as the distal stent. It was 2.7540 was used, and this was the final check angiogram done by that operator. Unfortunately, he has taken it with the balloon in situ. He hasn't taken out the balloon, he hasn't taken out the wire and all that. This was the last angiogram done. Okay, so this was at night 8 o'clock, and after a few hours I got a call from the ICU saying that the patient has got severe excruciating chest pain and he's developed hypotension, but the EKG was pretty normal, but a sinus tachycardia of 120 per minute, and the echo showed a moderate effusion with cardiac tamponade features with moderate LV dysfunction. There was no VSR or MR, and we had to do an emergency pericardiocentesis. So early morning, I took up for the pericardiocentesis first under fluoroscopy, and 250 ml of hemorrhagic fluid was aspirated. And again, I did a check angiogram. It showed a type 3 coronary perforation in the mid-LAD stented segment, which was overlapped with the distal LAD. So it was a pretty much oversight stent. Then we had to use a graft master 2.816. It was deployed at nominal pressures, like 17 ATM. After the final check angiogram showed a good result. So this was the post echo after the effusion was settled. The pigtail was put in for like 3 days, and then we removed it. He was managed with IV antibiotics, venoinotropic supports, and he was discharged on day 5. We put him on usual DAPT, beta blockers, and diuretics. Last month he came for follow-up. He's doing good. So coronary perforation is a known disaster. It is of 5 types. Type 1 is extraluminal crater without extravasation. Type 2 is pericardial or myocardial blush without contrast jet extravasation. The type 3 is the most sinister one, extravasation through fang perforation more than 1 millimeter. And type 3 with cavity spilling is perforation into an anatomic cavity, a chamber, or a coronary sinus. And there is a type 5, which is a distal vessel perforation caused by the wire. So how do you manage coronary perforations? First, don't panic. Always but inflate the balloon. Do a balloon tamponade to occlude the vessel. Start him on IV fluids, vasopressors. Always be ready with the pericardiocentesis set, and keep a surgical backup just in case. So monitor the patient. If there is persistent extravasation, just monitor the patient and send him back to ICU. Keep him on close monitoring. And if there is persistent extravasation, treat the cause. If there is a large vessel perforation, go for a covered stent, a Pabry stent, or a graft master, which is mostly available in our shelves, and do prolonged balloon tamponade, do dissection techniques. And if it's a distal vessel perforation, go for fat embolization if there are coils available, and a covered stent over a perforated branch as well. So if there is continued extravasation, we can try and use protamine to reverse anticoagulation. If nothing works, always send him for a cabbage. So my take-home points in this case was the operator didn't do a proper check shot in the end. He should have done it without a balloon, without the wire, proper check shot in caudal views as well as the cranial views. Always anticipate the complications. Always look out for pericardial.
Hello, sir.
Sorry? And always look out
The
for...
travel will start at 8:30 a.m. tomorrow morning.
So always do a check angiogram and always keep an echo in the echo as in the ICU as well as the cath lab, and always be ready with the bailout options. All these things are very necessary. There is a covered stent, the aspiration sets, the coils, portable echo. These things may seem very simple, but these are extremely necessary in case of an emergency. So thank you for the patient listening.
Thank you, Dr. Sindhu. That was a very nice case of perforation, very well handled. And your point is very well taken that at the end of any procedure, it's very important that we take out all our hardware and we take a long shoot, making sure to also look at the distal vessels, because many a times we miss the wire-induced perfs, which are the most commonly missed, and they are the reason for the 2 a.m. calls, which we get as an emergency. So very important to take shoots into orthogonal views at the end of the procedure with all your hardware out and to look at all the distal vasculature also. That would have probably saved this tamponade from occurring. And the second important point is that when you're doing interventions, it's, I think, there's always a bad day. The best interventionist also has a bad day. And it's very important that your cath lab should be well equipped with all the things to deal with such issues which occur inadvertently. Over to the chairs for their comments.
What are the covered stents available these days? I mean, we are just getting the Zion's covered stent. We are not getting the stents with the pericardial. I mean, Sarita, what I forgotten it used to come. There used to be another very nice stent with a good profile.
That was the papyrus.
Yeah.
The papyrus is not available in India currently, but if you talk to those people, they'll get it for you. But as such, it is not available for purchasing. But they do get it for you if you want. The stent which is most commonly available on everyone's shelf is the Graftmaster.
Yeah.
It's very bulky.
Very
That's
the
the whole
papyrus has a
problem.
much better profile.
Yeah, the papyrus would availability would be very much useful, right? Sindhu, you didn't try any balloon tamponade and anything. You just went ahead right away.
Yeah, ma'am. Because I knew once I saw the perforation, I knew it's been there for a long time. So, and then the Graftmaster was pretty much available. So I just took it and put it across. On retrospect, if I think back, now I would have suggested the operator to do an imaging because he clearly oversized the vessel size and then he has taken a 2.75. I would have not. So probably a 2.5 would have sufficed. That vessel size was definitely oversized. So now I can suggest an imaging. So that is one thing I could have done differently. So in retrospect, I can say that. And balloon tamponading, yes. But in this case, I just took the Graftmaster and I didn't want to wait. He was in cardiogenic shock. He was in continuous pain and all that. So I just put a wire across and then, just deployed the stent.
For large vessels, this would be the best approach, right? It was in the middle of the the artery. So that's the approach probably. Any other?
No, I agree because the patient already had tamponade. It was several hours down.
Yeah.
So his ACT levels would also have had come down by that time. So I think this would need to be sealed. So I think she did the right thing by using the Graftmaster.
Luckily, it was available for the patient benefit as well as in the midnight salvage. Otherwise, without Graftmaster, we could have done that way. That put a balloon and then tamponade and see his clothing or not.
Yeah.
But since you had a Graftmaster, you were lucky, patient was lucky, and thing was done immediately without much delay, so that the LV must have improved, I think so. It didn't get into that stunning and all. So you have done a good job.
So there is a question in the chat box by Dr. Sarita Gulati. Did you do a check angio later as Graftmaster do behave badly later?
Yes, ma'am. Incidentally, he came 2 weeks back for a follow-up. The stent is good, actually.
That's great.
Yeah.
Usually because with this Graftmaster high metal load.
Yes,
we
exactly.
tend to have higher rates of restenosis. So it's good that the stent is doing well.
There was a bit of slow flow, not that great, I must say, but there's a good Timmy 3 flow, but it's a little less actually. Not that great, but there's no ISR or anything else. The flow is pretty good. And now he's not having any chest pain. His LV has improved considerably. So I think it's good. Probably I can do an imaging maybe after 6 months later.
What is your approach in wire-induced perforations?
I did have a wire-induced perforation probably like 2 years back. That patient also presented like 4 or 5 hours later. But that patient settled with just conservative management. Wire-induced perforation, I can advise using a coil, ma'am. I've seen using coils and injecting PVA particles through microcatheter and fat embolization. So, as well as.
Yes. So it's usually the wire-induced which calls us back in the middle of the night.
Yes,
so those are the things. There's also one very useful thing in every cath lab and in every cardiac surgery attached. You have that Abgel sponges.
Yes.
You see, when you have a complication, you don't want to tell the patient again that now you have to pay for another procedure and you have to pay for the coils also. So the simplest thing is the Abgel hardly costs 10 rupees.
Yes.
Just scrape it off, mix it with little dye, take the micro and inject. No cost to the patient.
Yes, ma'am. Thank you, ma'am.
So, any other, Dr. Majela?
Yes, Dr. Sindhu, that was a great save. Hats off to you. Actually, you have discussed all the possibilities. There was any difficulty in taking the graft master in?
No, ma'am.
It was
The proximal stent was well deployed actually. So this time, I didn't have any difficulty in taking it, the graft master. They usually say the graft master difficult to negotiate in difficult RCA bends, probably the mid to distal RCA junction, and but LAD, I think it was comfortably going in. I was lucky actually, to be honest.
If we are not able to do anything, we are not able to take the graft master. But recently, I remember, I think you too will remember that for balloon tamponade, Dr. Trehan was saying that the pressures normally we go up to 8, 10 like that. Sir said even just 1 atmosphere is enough for balloon tamponading. That it's for balloon tamponade, that itself is enough. But if we are not able to seal the perforation, by all means, once it happened when I was also witnessing with Dr. Arun Kalyan for a CTO case. So that time only they demonstrate that we can raise a flap from the intima and we can seal the perforation. Though it is a very, very rare technique, very rarely used. If you're not able to do with any of the techniques in an emergency, still that could be an option, but it is the last option to be kept in mind. That was otherwise a great case. And actually, I've joined as not as the panelist, ma'am. By mistake, I joined in the other link, so I was not able to discuss. In the previous case, as rightly said by Jyotsna, ma'am, regarding brachytherapy, they even defined now brachytherapy is coming more and more into. So, for when we place more than 3 stents, definitely we cannot go for anything either for drug-eluting balloon or brachytherapy. So, in TCT, they've studied almost 300 patients, and they found that for the size of stent of 3.3, less than 3.3, it is 23 gray, the brachytherapy. And if it is more than 3.35, the stent size, it is 25 gray of brachytherapy. And in between, so 18 grays to 25 grays. So they've also studied that and they found that the outcomes are really good. Especially, we have to definitely avoid 3 layers of stents. 2 is acceptable, but when we have to go for 3, better not to do either a drug-eluting balloon or brachytherapy. I think. Thank you, ma'am. Thank you.
Thank you, Dr. Majela, for those excellent comments. There is one last question in the chat box by Dr. Gauri. She has asked, long stents, any room for DEB? Definitely. So today we are now looking at the hybrid approach, Dr. Gauri. So what we try to do now is, rather than put very long stents, the proximal lesion we usually try to stent it, and distally we try to do it with a DEB. So a hybrid approach is now coming in very well. And so if there are no further comments, we will now close the session. At the end, I would like to thank all our chairpersons, Dr. Bhanu Duggal, Dr. Tripti Dev, Dr. Majella. I would also like to thank our panelists, Dr. Varsha Kaul, Dr. Maria Jyoti, and Dr. Shalini Garg. It has been a great, scintillating discussion and comments. And I would especially like to thank our speakers who have done a fabulous job, especially Dr. Hani Sharma, Dr. Sindhu, Dr. Anuradha. Great presentations by all of you. And thank you so much and have a great evening, everybody.
Thank you, ma'am.
Thank you, ma'am. Thank you. Thank you. Lovely talks.
Thank you, ma'am.
Yeah.
Thank you, ma'am.
Very nice. Thank you.